everybody. I'm Ruth Kraut. I am with the Washtenaw Health Plan as a program manager. One of the programs that I coordinate is a Washtenaw Health Initiative program called CareNet, which is focused on helping care managers network and coordinate and learn about new things that are going on. And the big new thing happening October 1st is the Affordable Care Act marketplace opening. The whole year, I think, is going to be a whirlwind because Medicaid expansion is going to happen in the middle of this budget year. And so I am delighted that all of you could come to everything you wanted to know about the Affordable Care Act, but were afraid to ask. We did, a lot of you sent in questions with your registration, and we did get those questions. We shared them with the presenters. If you feel like they're not being answered, you should be sure to raise your hand. And some of them are as yet unknowable, but we hope to be able to answer your questions. So my goal for today is that when you leave, that you come back feeling like you know enough about the Affordable Care Act that you can share information comfortably with others. And so to that end, we have our first speaker today is Marianne Udow-Phillips. She is the Director of the Center for Healthcare Research and Transformation, and she's going to give you background, history, overview, and then we will later on today have Philip Bergquist from the Michigan Primary Care Association. We'll break for lunch. Lunch is on your own. And in the afternoon, we will be talking more specifically about outreach and enrollment. There are pastries, coffee, tea at the back. Please help yourself. If anyone needs to use the restroom, just go out the door to the left and to the left again. And with that, I'd like to welcome Marianne Udow-Phillips.
So bad, I don't know how to fix. But I might go fast enough. Yeah, what did she see? I have no idea. Good morning, everyone. It's great to be here. I love the title of this talk. I will tell you from the outset, I've been spending a lot of time in these past couple of weeks doing a lot of talks, Ruth heard me a few times, about the Affordable Care Act because there is so much confusion about this law and because it is so complicated. But I can tell you with assurance that I might not tell you everything you wanted to know about the Affordable Care Act because there is a lot to know. And in just about every presentation I've done, somebody asks a question that stumps me because there is a lot of technical detail in this law, some of which is yet to unfold, and some of which guidance comes out every day, and there's new things to learn every day. So if you have questions that don't get answered today, let me know or let Ruth know, and we will get you an answer to the question, at least to the best of our ability. So what I'm going to do this morning, what Ruth asked me to do was to give you sort of a broad overview of the law, and then give you some of the details of the law. I think Philip's going to go into more detail than I am. But to see, that was doing it on its own. So that, but to put it into some context, and I think the context is really quite important. And this is the issue of, why we're doing the Affordable Care Act, because the context for this law seems to have been totally lost in all of the discussion. I'm not sure I'd say we've had a dialogue about the Affordable Care Act, but we've had a lot of discussion about this law. And I think it really does help to have a little bit of background as to how we got here, what this law actually looks like in its broad terms, before you talk about the details of the law. So I really do want to back up. I teach health insurance in America at the University of Michigan School of Public Health, and we spend our first class going in great detail, much more than I'll do for you, about all of the history of health insurance in America and all of the different debates. I will say one thing for you, to the extent you follow any of the current debate and you find some of the statements a little strong, one has only to go back to the progressive era in the 1910s, between 1910 and 1920, and read some of the quotes then, when some of the proposals, which were much more mild than the Affordable Care Act, were described as an incitement to riot. So this, real challenge that we've had on health care has existed in our country since the turn of the 20th century, even really earlier than that. And we've had presidents or presidential platforms, not always presidents. Teddy Roosevelt himself did not recommend national health insurance, but the progressive platform that he ran on did. We have had presidents who've sort of tried to do things about health care for over 100 years in this country. And in almost every case, they've been defeated. Now, of course, Lyndon Johnson in 1965 was very successful in getting Medicare and Medicaid passed, and that really is the last time we've had major change to health care. But even that was enormously controversial in his time. And he was successful because he was an incredibly skilled politician, and he had an entirely Democratic Congress to work with. And probably more, or at least equally important with that, he had seniors on his side. Because in the early 1960s, healthcare costs were going up significantly, particularly hospital costs. And as this country had moved to more employment-based health insurance, which is the way most people in this country get their health insurance today, the people who got left out of that, of course, were seniors, because they weren't working. And they were so afraid that they were going to lose their health care coverage that they started grassroots efforts throughout the country and were enormously successful in overcoming the objections at the time. The objections to health reform at the time were principally led by the American Medical Association. The American Medical Association led these objections for most of the history until Medicare and Medicaid, where they were just soundly defeated. So Johnson was able to marshal that senior support, because of course seniors vote. They're a very effective group, and was able to get significant health reform passed, actually with the help of a former dean of the University of Michigan School of Education. Yeah. So that's really the last time we've had major health care reform. Richard Nixon proposed health care reform. He really did propose a very comprehensive, actually far to the left of the Affordable Care Act plan in 1971. Some people think he did it as a distraction from Watergate. A few of you might remember the Watergate scenario. But it was the last time we've had, before Clinton, a very significant proposal for health care reform. And that, of course, got defeated by Watergate, among some other things. So the next, really big foundation, and it's really important to understand this piece of our history that looked at healthcare reform, was in the 1990s with Bill Clinton's presidency. And in fact, he began the conversation about healthcare reform before he actually became president. After he was elected, he had an economic summit in 1992, and he had business leaders come to the summit. And quite interestingly, the auto company CEOs all went to the summit, and they all talked about the issue of healthcare reform and how important it was to do something about healthcare reform. And he heard that this message that healthcare reform was an economic issue, and he heard that the business leaders in our country wanted change on healthcare. What they overestimated was the power of that perspective and the specifics, the details that would go behind that. I said at the time, because I was very involved in looking at the Clinton plan and working actually with the auto companies at that point on their positions on healthcare reform, and and I was at Blue Cross and Blue Shield at the time, and I said at the time when we looked at what they actually did, that they could not have done any focus groups with any people, because what they really misperceived was that Americans, even though people, if you ask them on surveys, do you want universal coverage, people overwhelmingly say yes, they still do, and they overwhelmingly say that they're more dissatisfied with their health care. Americans say we're more dissatisfied with our health care than people in any other country, any other developed country in the world. But the reality is that people really don't like change. And something like 85% of Americans have some form of health coverage. And even if they complain about it, even if we all complain about our health insurer or whatever, for the most part, people are fairly satisfied with that coverage. And so what happened, so the Clintons made a number of mistakes. They had all these working groups. They had 500 participants. Most academics in the country were in this, but it was completely done in secret. There was no public discussion. There was no congressional involvement in what it was they were doing. And they released their plan in '93, and Hillary Clinton, led this task force. She went up on Capitol Hill. She presented her plan, and there was an initial positive response. But in the end, the opponents were easily able to marshal public opinion against it, and they did it by running a couple of ads, most of which ran within the Washington Beltway area. Some of you might have heard these ads called Harry and Louise, and they were this nice couple that sat on a sofa, and they were talking about this managed competition idea, and they basically talked about how scared they were that they were going to lose what they had. And that gave enough cover, because it wasn't like Johnson and the seniors. There was no unified voice, and even all the business leaders that Clinton had heard from, in the end, they started hearing from their fellow colleagues who were CEOs of the pharmaceutical manufacturers, CEOs of the insurance companies, who did not want this change. And so that effort really brought this to a crashing defeat. So now it's going backwards by itself. Okay. So that sort of brings us up to Obama and the Affordable Care Act. And so Obama heard something similar to what the Clintons heard. He heard also that people were very concerned about health care. He also, like the Clintons, believed that health reform is an economic issue for our country, that without having some form of universal coverage, without having some mechanism to deal with healthcare costs, we have serious economic problems. Healthcare costs now take about between 17 and 18% of our gross domestic product. They've been growing consistently, and he felt, and his team recommended that in addition to the stimulus, that he ought to focus on healthcare, and he took a number of lessons from the Clinton years. One of the lessons was that you have to, if you're going to do something on healthcare, you have to do it early in your term, and you have to do it fast. So when people go back in history and they say, why did he take on healthcare? They should have focused on the economy. Well, he wanted to do something in his presidency on healthcare, and he knew that he'd have about 100 days to do it. That's what the typical plan for any president is in terms of getting major legislation through. And so if he didn't do it in the beginning, he wasn't going to do it. And he took from the Clinton years that it would be a terrible mistake for the White House to write a bill, give it to Congress, and expect them to pass it. So sometimes you hear a critique of Obama that he wasn't leading. He laid out his principles, and then he let Congress do it. But that was something he had learned from the Clinton discussion, that he needed to have Congress take the lead on this. The other thing he learned that is fundamental to what we're going to talk about in a moment, and to really understanding the Affordable Care Act, is that Americans actually don't want a lot of change. That as problematic as the current structure of healthcare is in this country, that really in the end, people don't want a lot of change. And that is the fundamental reason, frankly, why the Affordable Care Act is so complicated, so complex, so difficult to understand, and has got a number of problems with it, because it doesn't try to change the fundamentals of healthcare. And we'll talk about that in a moment. So they designed a law that they thought was going to be bipartisan. And ironically, the law that they designed was built on something that was proposed during the Clinton years. It was proposed by a conservative think tank called the Heritage Foundation. And it was this idea of an individual mandate. And the principle behind the individual mandate is the same as it is behind requiring people to have auto insurance if they drive a car. The idea is that you should have to have, people should have responsibility. People should have personal responsibility for making sure that they have health insurance. Because when you don't have health insurance, when you're uninsured, that does put a societal burden on people and an economic burden on others. When people go to the hospital who are uninsured, there are costs that are incurred from that hospital visit. Hospitals are required to stabilize somebody who's uninsured, and those costs do get passed on. They're not just magically gone. They do get passed on to others. And so this was a philosophical belief that the way we should reform healthcare in America is to require individuals to have responsibility. I will tell you that when that was proposed in the mid-1990s, during the Clinton debates, the Democrats in Congress said, that is a terrible idea. That is such, this should not be individual responsibility. We should look more like other countries, Canada, Great Britain, whatever, where it's a government responsibility, where it's an employer responsibility, it's a public responsibility, not an individual responsibility. They thought that this was really just a terrible concept. So you fast forward from the 1990s to 2009, when we're having this debate about healthcare reform, and the leaders in Congress, the Democrats in Congress at that time, thought that, well, maybe if we had only embraced in the mid-90s that concept, we would have had health reform today, would have been bipartisan, we'd be better off than where we are. So let's not make the perfect the enemy of the good. Let's go with this idea that came from the Republicans, and let's build as many ideas that they've proposed in as possible, and then we'll have a bipartisan healthcare reform in this country. I think most of you know that's not exactly what happened. They got one vote in the Senate from a Republican for the law at a debate point, but not in the final law. And so it was passed ultimately only by Democrats. And that's sort of led also to the legacy and the debates we continue to have today. They had passed a law in the Senate and in the House that were not the same, and they were still in the middle of the debate when Senator Kennedy died. And there was a special election in Massachusetts. And Senator Kennedy was a huge proponent for healthcare reform. But the election in Massachusetts led to a very surprising outcome. A senator named Scott Brown was elected, and he was a Republican. And so they lost their filibuster-proof majority in the Senate. And he ran sort of on a platform that was sort of against the Affordable Care Act, although he turned out to be a fairly moderate senator in the end. He lost his re-election bid to a Democrat, but he was there for one term. And it became clear that he was not going to vote to support the Affordable Care Act. And this is also quite important, because what ended up happening then as a result of that election is that the Senate version of the Affordable Care Act is what they ended up having to adopt with no amendments to it. No amendments to it. So normally in a process when a bill becomes a law, you have the Senate and the House pass something, they're somewhat different, they meet in conference committee, they talk about it, they look at the things that maybe don't make sense, they have more time to fix things. They had no time and no ability to fix things. So when you hear that there are a lot of mistakes in the law, we had a lot of 28-year-old staffers staying up until 3 in the morning writing this Senate bill, and normally you have somebody go back through it and fix all that stuff. They had no ability to do that. So there are indeed things that they would have done differently if they had the chance. There are mistakes in it, and as I'm sure you know, they've also not been able to fix those because ever since then, the law has been so politicized they've not been able to they made a couple of changes, but not very many to this law. So that is, how we got the law that we have. And I think what's really important to understand, as I said, is that this is largely an incremental law. Again, if you just listen to the news media, you might think that this was this radical federal takeover of healthcare, but in fact, it is nothing of the kind. It is a big law. There's a lot of change that's happening with this law and all the dimensions in healthcare, but it is an incremental law because, as I said, what it is doing is building on our existing system without changing any of the fundamentals. I would, by the way, defy any of you to explain our existing system. So when you see all those surveys that say people are incredibly confused about this law, well, I think people are incredibly confused about our current healthcare system, and this just, as I say, adds a lot of complexity. Probably, if I asked any of you to explain your health insurance policy, you'd be just as confused about that as well. But really what it does is builds off the way we currently get coverage. So it expands both the private and public sectors, and it corrects the market. One of the big issues with the market, much more so outside of Michigan than in Michigan, is how many people who were sick and who need health insurance coverage can't get it. And they can't get it because they have a pre-existing condition, they were sick before, and they're excluded from coverage as a result of that. They can't get it because you have insurance companies, you had insurance companies, particularly in places like California, who you'd get health insurance and you'd end up in the hospital and they'd go back and look at your records and they'd find something that you didn't tell them about, and they take it away retroactively, right? So there are a lot of people, and in this era that we were in, in this last deep recession, 2008, 2009, lots of stories about people who, number one reason people were becoming bankrupt was because of medical care expense. And that's because a lot of folks could not get health insurance, and so it's designed to fix the market. It's a fundamentally market-based approach to healthcare. It's really saying we need to have a better market, we need to correct a lot of things in the market, and that's what it's about. So it does, despite what people say, it does include a lot of cost and quality strategies. I'll talk about those. And we just saw some new data last night. It will have a modest increase in cost because we're covering a lot more people with broader benefits than they have today. But it barely changes the projections on the percentage of gross domestic product that we'll be spending on healthcare in the near term. And the original law, when it was passed, it did reduce the deficit. There are a lot of assumptions behind those reductions. We'll see if they come to pass, but it was based, and again, it's important to understand because people ask questions about, well, why was it done this way? It was done so that they could say that it reduced the deficit, whether people believe it or not. And of course, it was enormously challenged by many in the legal system after it was passed, and it went to the Supreme Court in late 2011. They ruled on June 28th of 2012, and there were 4 issues that they were ruling on, and the issue that people thought they were going to really, or many conservatives thought, and very important in terms of what happened in Michigan, many leaders in our Michigan state legislature thought that the Supreme Court would rule this idea of the individual mandate would be unconstitutional. They did not. They upheld the individual mandate, but they ruled one piece of it, of the law, as unconstitutional, which is quite significant. They ruled that the penalties that the framers had included for states that decided not to expand Medicaid, because, again, it's building off the current system. So for states that don't expand Medicaid, the Supreme Court ruled that the penalty that was included was too severe. Okay. It's haunted. So they ruled that the penalty was too severe and that they struck that down as unconstitutional. The penalty would have been that states would have lost all of their Medicaid funding if they did not expand Medicaid coverage to all those contemplated under the law. They said that you couldn't do that. And that made Medicaid expansion voluntary by the states. And that has been the debate we've been in our state and many states over the past many months, and I'll tell you how that's gone in our state in a moment. So that's the one piece that they did not uphold. So, this is the fundamentals of the law. To the extent that we want to provide universal coverage in our country, and as I said, if you ask people in polling data, they all say they do. There are only a few ways to do it. You can do it through a tax-funded system like they do in Canada, in England. You can do it through an employment-based system and fill in the gaps like they do in Germany and Japan. And that involves mandates to employers and to consumers. There are no other ways. You will occasionally hear in the Republicans yesterday in Washington came out with their alternative to the Affordable Care Act. Their alternative to the Affordable Care Act is malpractice reform, higher copay and deductible programs for consumers, and allowing health plans to sell across state lines. Those proposals have been around for a long time, and the market has been in place a long time, and that does not get us to universal coverage, or even close to universal coverage. There are only a couple of ways to do it, and what this law did was sort of do both. It combined a mandate type approach with tax-funded programs, with expanding Medicaid as a tax public program. And it requires almost everyone to have health insurance. We'll talk, I think, between Philip and I later about there are people who aren't required to have health insurance. There are exemptions from that, but most everybody is required in one way or the other to have health insurance. It does expand, or contemplated, not every state's doing this, but it does expand Medicaid for poor people and subsidizes private insurance for people who are below, for some people who are below 400% of poverty, which is about 92,000, 94,000 for a family of four. So for a lot of people, it provides subsidies to buy private health insurance. One word about Medicaid, something that you may know, but many people don't. One of the things it was trying to do, and that's why I describe it as an incremental law, because it's really trying to fill in cracks from prior laws. So when Medicaid was first developed, it was developed based upon the old social welfare systems that were established in the 1930s. Different from Medicare. Medicare was based on Social Security, right? So in Medicare, you sort of had a category of people. Everybody over 65 becomes eligible for Medicare. That is not true with Medicaid. Many people think that Medicaid covers poor people. And you do have to be poor to get Medicaid, but you also have to have other characteristics. You can't just be poor in the current Medicaid system. You have to be old-aged, blind, disabled, a parent with children, foster children. You have specific categories. That's why it's called a categorically eligible program. And many poor people today are left out of the Medicaid system. So the Affordable Care Act said, that's real. Let's change Medicaid to make it look more like Medicare, where you have a category of people that have coverage, and really make it a program for the poor. And so it said that everybody who's below 138% of poverty, which is $15,900 for a single individual, would be eligible for Medicaid. Everybody. And so that would really fill in the gaps. That means in our state, and I think most states, a lot of single people, a lot of males who don't have children in particular, and frankly more younger people become eligible for Medicaid under that expansion. So it's a somewhat different population than is in there today. And the last thing, which is also a little, well, everything's controversial, but this has had a lot of discussion recently, is that large employers were also required to offer health insurance and automatically enroll their employees and inform them. And in fact, some of you may have gotten your notices from your employers today. They've got to inform employees of their availability of a health insurance exchange and whether or not they have credible coverage, and lots of employers are sending those notices out right now, so you may already have seen some of that information. So I told you earlier that one of the goals of the framers of the law was to reform these terrible insurance practices that have left so many sick people out of the ability to get health coverage. And I want to hear for a moment just to explain a principle of insurance that seems to have eluded many of the critics of the Affordable Care Act, but it is so fundamental to understand this and understand how these things work. So, the whole concept behind insurance is that we don't all get sick at the same time, but we all get sick at some time. And if we all pay a little bit, may not be just a little bit, but if we all pay something and pool our resources, then we can cover a group like this for the people in the room who get sick, and we'll have enough then to cover people later when they get sick, right? Because we keep paying in our money, but we get sick at different points in time. It is the concept of pooling the risk and sharing the cost. That is a fundamental principle of insurance. Insurance only works when you have a mix of people. If you had people in your plan who were all sick all the time, that's not insurance, because then the money that you're pooling is essentially covering the actual cost of your medical care, right? That's not insurance. Insurance is spreading that risk and spreading the cost. And so you've got to have everybody in. And that is why they have an individual mandate. That is why they have the employer mandate. That's why there are penalties for people who don't get insurance. The idea is you can't just have a plan that serves sick people. You've got to have a program that includes everybody. And if you look at how the health plans are now marketing themselves on the health insurance exchange, they're using a tremendous amount of social media. Some of you may not see how they're marketing because they are targeting young people. They're targeting folks who go on Twitter and who go on Facebook because it is really, for this law to work, for this to be able to be true, you've got to have younger, healthier people in the mix. That is going to be the key to success here. If we don't, these insurance practices will continue. I have lots of friends who are actuaries. Most of my friends are mostly the good actuaries, but some of the bad actuaries in the world have spent their careers trying to figure out and predict who's going to get sick and keep them out of health insurance, right? That goes away under the Affordable Care Act. That is a fundamental principle of the Affordable Care Act, but that cannot go away unless everybody is included. And actually what the insurance companies were concerned about, and I think I showed this to you later, is that the penalties for not having insurance they feel are too weak. They want the penalties to be higher. So I think that's really quite important. The other thing the law did was to expand preventive coverage. Again, the framers, everybody's been really surprised, I would say, at the reaction to the Affordable Care Act. Very surprised. And if you go back and you look at some of the quotes, they'll say, oh, people hated Medicare, but then they loved it. And the framers built a lot of things into the Affordable Care Act they thought people would love. And this is, whoops. Let's see. This is one of them that they thought people would love because it provides more coverage for everybody, more preventive care services, and they really felt consumers would love it. The problem is that, frankly, people don't associate those expansions of their coverage with the Affordable Care Act for a number of reasons. One being it's rolled out very slowly because they were trying to cut the deficit. That was one issue. And two is because it's so complicated, and frankly, they've done a terrible job in explaining it to people. Terrible job. But it does include more preventive care services. It eliminates lifetime limits on benefits, and on January 1st, it will limit annual limits on benefits. Many health plans had dollar limits. You couldn't exceed more than a certain amount, and if you're very sick, that's really problematic. And it requires that there be these qualified health plans that get offered through what they called health insurance exchanges. You'll probably see it more commonly described right now as a health care marketplace, because healthcare exchanges didn't test very well in focus groups, so they're calling it a healthcare marketplace. And the exchanges are essentially intended, all of these things actually, essentially intended to make the market work better, to help consumers have, be able to get access to care, and to help consumers make more informed decisions about what healthcare plan they're getting. So it's supposed to be like Travelocity or Expedia, where you get your healthcare and you can compare your healthcare plans online, and it can be clearer to you. And it was designed to somewhat, although it doesn't do this perfectly, to somewhat standardize benefits. So everybody has to have what they called essential benefits. The law listed 10 categories of those benefits, and then in the end they left the details up to the states, which is fairly significant. And it had to have a minimum actuarial equivalent value, which simply means it had to cover a certain percentage of healthcare expenses that people anticipated would be incurred with use of these essential benefits. The minimum is 60%, with a slight variation for catastrophic plans. So it has to cover at least 60%. And I'll tell you right now, before we go too much further, that what most people are expecting, most independent observers, most actuaries who are not politically motivated would tell you, is that the predictions are that what will happen as a result of the Affordable Care Act is many more people will get coverage. They'll get broader coverage, better coverage with better benefits, but they'll have higher copays and deductibles than they have today. So that is the prediction about how all of this will play out over time. So I want to say, go into a few more details just because it's so confusing to people, and I think important to understand. So one of the myths, and if you saw my interview, this was one of the things I was addressing on this, because so many senior citizens are really concerned about this law. As I say, a lot of what you see in the media, or if people follow it at all, is misinformation, and seniors have been made very afraid of the Affordable Care Act, when in fact the Affordable Care Act does very little to change Medicare. It does change how hospitals and doctors are paid, and changes a number of things around Medicare, but in terms of the benefit plans for seniors, it does very little, and to the extent it does anything, it adds benefits for seniors. And as I say, very few seniors associate these added benefits with the Affordable Care Act. They in polling data, are fairly negative about the law. They don't just know that it did these things. So they've already gotten more preventive benefits with no cost sharing. They've already gotten reductions in what's called the donut hole if you need prescription drugs. When the Medicare Modernization Act of 2003 was passed, they passed drug coverage, but to make the numbers work then, they had this kind of deductible in the middle after you spend a certain amount of money, and it reduces that donut hole. Seniors already got $250 checks the first year this law went into effect to reduce that donut hole again. They didn't know it was from this law. And it brings the coinsurance rate down quite significantly until 2020. There are lots of quality improvement and demonstration projects related to the Medicare population in the law. And it does to, one of the funding provisions, there are some new taxes in the law that hit various different segments, and there is a tax increase for Medicare recipients that are high income. And the high income is $200,000 a year for singles and $250,000 for a couple, and it's an increase in the payroll tax of 0.9%, which is intended to fund portions of the expansion of coverage in this law. So that's all that happens with Medicare. It's not a fundamental change to Medicare. Now, many things have already occurred under the Affordable Care Act. Many more things will go into effect starting January of this year. But these are examples of things that have already happened as a result of the law. I told you about the drug rebates. The one that people really like, and more people I think actually do associate this one with the Affordable Care Act, is the fact that if you have children up to age 26, they can now stay on the parents' policies, and that's been an extremely popular part of the law. Of course, there's these other things here. Small businesses have gotten tax credits. If you ever go to downtown Home and Garden store, Mark Hodesh got a tax credit. He's gone around talking to people about how he was able to hire more employees as a result of that. He's very favorable about this. These lifetime limits are gone. and the preventive services have already gone into effect. And there has been an early retiree insurance program that's helped businesses who provide coverage. People were really worried that businesses would start dropping coverage before the law went into effect. You hear a lot, and we can talk about it, about businesses changing or dropping coverage now. People really didn't want this to happen before new coverage options were available, and so they provided some incentives in the law for people to keep people covered until 2014. I'll talk about what other businesses are doing now. It's not, much of it is not related to the law. So lots of things have already been implemented, but the big coverage changes are going into effect now. So starting in 2014, this is when the individual mandate goes into effect. Most people, not all, most people are required to have some form of minimum essential benefits. All these rating changes go into effect in 2014. So all of the ability of health plans to rate based upon your medical status, to exclude you based upon medical status, et cetera, goes away in 2014. Many health plans rated women at higher rates, provided health coverage that would cost more for women because of maternity benefits. That goes away. Except for people who work for very large employers. So very large employers exempt from a lot of this, as long as they offer coverage. Ruth said earlier that in Michigan, we will be expanding Medicaid. We had a very long and hard debate about the Medicaid expansion in our state. It was a very tense debate, and when they did pass it, and they were not able to pass a companion piece of it called immediate effect. And because it didn't get immediate effect, what that means is that it does not go into effect until 90 days after the legislature adjourns. That's sort of standard practice for laws, that there's a 90-day waiting period, but almost every bill this year in this legislative session has gotten immediate effect from the legislature. It's kind of been a routine practice. They were not able to do that for Medicaid for a variety of reasons. And what that means is, we don't know exactly when the legislature is going to adjourn this year, but assuming it is towards the end of the year, to the end of December, it probably won't go into effect until April 1st, or so. And just to be clear, in case there's confusion about this, what that really means is people won't even be able to determine if they're eligible and sign up until April 1st. Okay, so it's not like we know Medicaid's going to expand in our state, so you can get your eligibility now, and they'll just hold it and make it effective April 1st. That is not the case. They will not start enrolling people in Medicaid until it goes into effect, which means that there are many people who actually won't get the coverage, maybe till May, because they've got to determine that you're eligible first. So that's a piece. It's a complicated piece, because some of those people will become eligible for tax credits and might get coverage on the health insurance exchange. We can talk about that. The employer mandate, I talked earlier about, this combines growth of public programs, individual mandate, employer mandate. The employer mandate was delayed until 2015 for a number of technical reasons. The employers really asked for that delay because they had a lot of challenges in getting certain elements of this law. There's some very complicated elements from an administrative standpoint. They had a real hard time getting some of those elements put in place. And the employer mandate, some people would say that the employer mandate was kind of an afterthought, that it was, it's really not particularly crucial to expanding health coverage, because more than 90% of those who are going to be affected by the employer mandate already have health coverage through their employer, more than 90% in the country. So the big eligibility expansions come with the individual mandate, particularly for people who are uninsured and who will now have choices of health coverage on the health insurance exchange, and with the Medicaid expansion. Those are the big areas where you see the impact of this reform. It's not really in the employer market. So delaying this didn't change much in terms of coverage. It has some complications administratively to do it, but on balance, it doesn't make a practical impact. And then in 2018, you'll sort of hear this discussed, I think, starting now as people sort of move on beyond 2014, let's hope. There is a tax that goes into effect on very high benefit health plans called a Cadillac tax. I was talking about this with our students. It's really great that the U.S. and Michigan are still recognized as having really very luxurious cars with Cadillac, but maybe we didn't want to be associated with a Cadillac tax. We could have picked another term. But the idea behind this is to say that, and this is sort of the economist's view of healthcare. The economist's view of healthcare is that we have the worst system in the world because the incentives are all wrong, because health benefits provided by employers are tax deductible. And what that means is it's an extremely regressive tax. So first of all, it's the biggest tax benefit in the country by far. It goes way beyond tax benefits for mortgages or anything like that. So it's the biggest loss of income at the federal level is the tax deductibility of health care. It was adopted in the Eisenhower administration. They had no clue what it would cost. They just said, oh sure, we'll make it tax deductible. And it is a huge loss of revenue to the Treasury. But from an economic standpoint, it is a regressive tax because it really benefits high-wage workers far more, because it's tax shelter dollars providing health care, far more than giving those workers $1 in wages, right? So the economists have long wanted to get rid of the tax deductibility of benefits. You do see that in some proposals. Paul Ryan, in his proposals for health care reform, if you followed any of that, proposed eliminating the tax deductibility of benefits. That is not a politically popular stand to take. I will tell you, it would be a huge transfer of cost and probably not achievable. So these framers, tried to achieve it in a small way. They said, well, we'll put a tax on the high benefit plans because we'll try to make this a little bit more price sensitive. So that's what this Cadillac tax is. So let me look in a little bit more detail at what's happening around the country. This is an old chart. I'm actually surprised we didn't we did update. So this is the picture, and actually I just saw a new map yesterday, which we'll have to adopt. That's really quite interesting. This is the picture of the Medicaid expansion in the country. And you're going to see a very similar pattern when we look at who's doing a state-based exchange. And I don't know that there's anything particularly significant in the fact that blue was chosen for the states that are expanding Medicaid, but there is a pattern there that you could look at. And in the latest map, I saw all these, what are chartreuse or whatever in this map, were red. So it was rather an interesting map. So this is what it looks like across the country. And the sad thing, and it's changing a little bit, but it's going to be pretty stable. The sad thing about this is that millions of very poor Americans are going to be left out of any benefit from healthcare reform. Texas is the state in our country that has the highest rate of the uninsured. 25% of residents of Texas are uninsured. And they have not only decided not to expand Medicaid, but they're actually putting tremendous barriers in place to navigators and other people that are trying to help people get enrolled with tax credits on the exchanges. Florida, same story. Yes?
What's the rationale that politicians are using for not expanding? Can you just simplify that? I think it's really complicated.
No, it's not a complicated rationale at all. It's a hard rationale to defend because it's not particularly a rational rationale. What the rationale that they're saying two things. They don't like government. Now, these are politicians who are paid by government who say this, but they don't like government. And you can't trust the federal government because they're offering 100% of funding in the first 3 years. It's not for 3 years, it's the first 3 years. So Michigan does lose, by the way, $600 million by delaying the Medicaid expansion until April. That doesn't come back to the state. So they're saying you can't trust the federal government to stand by its promises, even though there is no evidence the federal government has ever withdrawn highway funds or Medicaid funds or whatever. So it's just, I read a quote today that I just loved. It's a sugary snack that this is from a conservative opposed to the whole Affordable Care Act. It's a sugary snack that you're going to get sucked in by, and then they're going to take it away and you'll be addicted. That is the quote of what they say. You can't trust the federal government to keep paying. What I would tell you, I really think it's very hard to see this as other than an ideological view. But it is a view. There are some very strong individuals who are libertarian, who really do believe that we shouldn't have as much government involvement as we do, and probably would repeal, if they could, existing Medicaid, existing Medicare, and go with an entirely market-based system. So I think there are some people who just very strongly hold that philosophical belief about how we should govern the country. But there are many others that I think it's much more an anti-Obama view. And it's very hard to see the rationale. In Michigan, every group was in favor of the Medicaid expansion except one. And the groups that were in favor it was one of the most bipartisan, one of the most cross-sector efforts that I've seen in our state. We had the Michigan Chamber and the Michigan Small Business Association, extremely conservative groups, business groups in favor. We had, of course, all the consumer advocates, all the providers, all of the health plans that were in favor. There was only one group that was opposed. There was a group called Americans for Prosperity, and it's closely affiliated with the Mackinac Center here in Midland, Michigan, which is essentially a libertarian group. So the opposition has been philosophical more than it has been some practical issue. There have been practical issues raised, but that's not really what the opposition's about. And it's tragic, I really believe, because the people who get left out, by and large, are very poor people in the country. The people who are making the laws are people who have health insurance, not the people who don't have health insurance. So I find it difficult personally, those decisions. So this is what Medicaid in Michigan looks like. This is what got passed by the state legislature. It is essentially, providing coverage for people up to, as I said, up to 138% of poverty. That's $15,900 for a single. And it's continuing sort of the Medicaid program we have with a few little twists. So basically, the coverage will be provided through managed care organizations. It's quite interesting because of term limits in Michigan. Many legislators didn't understand our current Medicaid system. And the state Department of Community Health staff did sessions. They worked tirelessly, and the governor came out early in support. So Michigan, even with a Republican governor, Governor Snyder totally understood the economics of this, that this was so beneficial for the state in so many ways, and he was really delightful at the signing ceremony, which was on Monday. And he talked about how many people will be helped, as well as the benefits to the state. The staff, though, had to go and spend a lot of time with legislators who said, well, we need a private sector solution to Medicaid. And they said, we have a private sector solution to Medicaid in Michigan because it's implemented through managed care companies. So in Washtenaw County, Blue Cross Complete is the largest Medicaid health plan, and it's it's owned by Blue Cross and Blue Shield. So Molina Health, there's some others that are very large, and they are private. Yeah.
How is this going to affect the reimbursement rate of Medicaid?
To the providers or to the health plans?
Providers.
To the providers. So the law, they only made one change on the reimbursement rate for providers. What it did was for 2013, this year, and 2014, with 100% federal dollars, it raised the amount that primary care physicians are paid to 100% of Medicare rates. Medicaid is, other than the uninsured, is the lowest payer to providers of any health coverage. There was concern that when the law went into effect that there wouldn't be enough providers. I will talk about that. I'm going to show you that in a minute. To provide care for the Medicaid recipients. And so they raised the rate for primary care physicians only, not specialists, to 100% of Medicare, which is a very significant increase. The hope is that the states will pick up that additional higher rate after 2014. And because there is enormous savings, we'll show it later, to the state, Governor Snyder has said he's going to put at least half those savings into a special fund to be used for the Medicaid program. We projected that Michigan will save, as a result of this, over $1 billion over 10 years. $1 billion over 10 years. And that is primarily because today Michigan pays for a lot of mental health care through the community mental health system using state dollars. And people will become eligible for federal dollars because there is mental health parity in the Affordable Care Act. So that's a big part of why we save money in Michigan as a result. There are many other reasons why we save money, but that was the single biggest component. So the legislator, one of the debates in the legislature was, and they won't describe it as, some of them won't describe it as a Medicaid expansion. They will describe it as a Healthy Michigan program. The press has kind of seen through that, and they describe it as the Medicaid expansion. But it was very important for some legislators to say, we didn't do the Medicaid expansion, we did our own program in Michigan. And we made sure that the enrollees, as they put it, this is their quote, had skin in the game. And so we required, they will say, the enrollees to pay 5% of income in some form of cost sharing. They left the details of that cost sharing up to the Department of Community Health. So it's unclear whether that'll be in the form of copays, deductibles, a percent they have to pay on the premium, but it'll be some mix of that probably. They can, some enrollees, they're going to set up a prepaid account, kind of like a health savings account, where enrollees can put money in to be used to pay for that 5%. And it can be lowered if enrollees engage in healthy behaviors. So they have wellness plans. Yeah. No, and that's why it's actually not called a health savings account. It's called a private account to cover out-of-pocket costs, like a health savings account. So it doesn't fall under the IRS code. So they have to figure that out, but it's not exactly that.
So it's not implementable at the moment, but it's
No.
going to be developed
Right.
for all individuals who are down in.
Well, that's a question. It's going to be developed for the people who get the expansion, so not necessarily those who are currently eligible. And of course, I think you know that the expansion applies to people who are eligible who don't meet current eligibility rules. So it's not just that people who are currently in the program have slightly different structure. Those people who would have met current eligibility rules into the future have a slightly different structure. So how the department is going to make all this work and whether it'll look like it's the same applied to everybody, that's yet to be determined. These things do require, this part here in particular, does require a waiver before it goes into effect. I don't think it's going to be a problem for them to get that first waiver because it's all permitted under the law. The law permits 5%. It's a cap of cost sharing for people up to 150% of poverty. Over 100%, it's a limited population. So I don't think they'll have a problem in getting that particular waiver. This piece, which has been pretty controversial and which the advocates closed their eyes to when they went and said, yeah, we'll support this law, they just sort of holding their breath would be the way I would put it. It was a second piece that, this one. Oh, we did do the 7%.
Can we do that so they just on the next one?
I'll come back to that.
Can you say what you're pointing to?
Yes, I'm sorry. But I'm pointing to the wrong thing because it's on the next slide. So this one is that, but it is an important point, this one, is that individuals can enroll, once Medicaid enrollment starts, people can enroll at any time. So in the health insurance exchanges, there's an open enrollment period, October 1st through March 31st. That is not true for Medicaid. People can enroll anytime. It's continuous enrollment. Yeah.
In terms of our particular health plan, it actually expires outside open enrollment. Have we figured out yet how that's going to work?
So your health plan expires in
It will actually expire June 16th.
of 2014. June 14. So people, if they have a qualifying event, if you don't no longer offer health insurance, and your employees then become eligible for health insurance on the exchange, they can get it at that point. So the open enrollment period is an enrollment period for people without qualifying events, but an employer terminating coverage would be considered a qualifying event, so they could enroll at that point on the health insurance exchange. The other thing that's important to know, I might get to this later, is on the mandate that the penalties only apply for people who are uninsured for more than 3 months. So if there's a little gap, that's also not a problem. In your case, if they had to wait to open enrollment, it'd be too big a gap, but they will be able to enroll at that point, if you don't offer insurance. Okay, so here's the federal waivers. So these are the things, as I said, that are required for the first federal waiver. So one of the ones I didn't mention to that is included in the law, which is also kind of interesting, I think it's a good thing in some ways, is that all enrollees will be required, all new Medicaid recipients will be required to have an advance directive. I think everyone should have an advance directive. I think it's a fabulous thing. I do find it kind of interesting that one of the critiques of the Affordable Care Act and one of the things that launched all the animosity was this idea that there would be death panels in the Affordable Care Act. But there was no discussion about death panels when they debated this, added this point about advance directives only applying to people in Medicaid. So these things have to be approved for the first federal waiver. There is a second federal waiver that is required. And that's the point that I was trying to make before that is much more controversial. And it is that after people are on Medicaid for a collective 48 months, cumulative 48 months, they can stay on Medicaid, but their cost sharing, if they're between 100 and 138% of poverty, goes up to 7%. Now, that is not permitted statutorily today. 5%, as I told you, is the cap today. So going up to 7% is something that the Secretary of HHS could approve. We think she has the authority to approve that waiver. We're not sure if they will approve that waiver. Now, that waiver is not necessary for the Medicaid expansion to go into effect. It's not needed until December 31st of 2015. And so this is why I said the advocates and all those who are supporting the Medicaid expansion just sort of held their breath on this one and are hoping, frankly, that we'll have a different legislature by that time and they'll change that, because people really find that a very difficult piece to think about, people paying 7%. Yes?
Could you go back to the previous slide?
Yeah.
It says enrollees will be required to make account contributions for cost sharing expenses, and that's kind of before they can get enrolled?
No.
Does that kind of present a situation where people have to have cash in hand to go in and sign up for?
No, and that's, as I say, that's kind of left up to the health plans to figure out, and it's not all enrollees, and it's this health savings account-like thing.
Right.
What they have to have is have that available, and so the law is silent on exactly how that will get implemented. The department will have a lot of latitude in setting that up. I am confident the department is not going to put barriers like that up for people. No, I am confident they're not going to do that. I'm pretty confident what they're going to do is have some sort of account that people can put $5 a month or whatever into that can accumulate over time that can be used for this purpose. I'm not worried. And knowing what they're trying to do, I'm not too worried about how it's going to be implemented. But this one I think is a bigger issue. This going to a 7% cost sharing is going to be a bigger issue for families and may discourage people to becoming enrolled if they think they have to pay that much for health insurance. And we're going to have to see what happens over time. It is only for those between 100 and 138% of poverty. They have the option of getting health coverage on the health insurance exchange with a tax credit. This idea of the 48 months was not the governor's idea, but the legislature, as some of you might know, passed this relatively recently for people on welfare, and they liked the concept so much they thought that they should apply it on health care. People don't get sick necessarily within 48 months. It's a kind of different thing, but we'll see. Yes?
Is that 5% based on gross annual income, or is it
Yeah.
based on-
So, again, the rules aren't out. We don't know exactly how it'll be applied, but the eligibility for Medicaid is now based on modified adjusted gross income, MAGI. And I expect all of this will be based upon that same method because that's what's going to be calculated in terms of the eligibility.
Do you think the incentive of having that 7% reduced by
Wellness programs.
adopting or participating in healthy behaviors, do you think that is an incentive that will be helpful and motivate people to?
I think we'll have to see. It could be. What I'll tell you from the from the research in the private sector. So many private sector employers do this now. They usually do it through carrots. If any of you work for the University of Michigan, you get a M Healthy program gives you a bonus if you engage in some, the different programs that they offer. whatever. In this case, you could look at it as either a carrot to engage in behaviors or as a penalty if you don't engage in those behaviors. They built this off a plan that Blue Cross and Blue Shield offers called Healthy Blue Living, that they offer through their HMO. What Healthy Blue Living has found is that it is a program that does save money for the employer, but it frankly doesn't save that money by having consumers more engaged in health behaviors. It saves money because so many consumers don't engage in those health behaviors that they pay the higher rate. And so, does it act as an incentive? The problem with most of these programs in the research that we've seen today is that mostly what you have are people who are already motivated and who are already engaging in these behaviors who participate, and people who don't participate tend not to be. Now, it's all the research that's been done has been done in an insured market with employers. So I don't know what it's going to look like. We don't have any data on what it would look like with this population. What I do know for this population is that some of the behaviors people engage in that are unhealthy, such as smoking, is much more prevalent with people who, for example, have depression. And there is a much higher rate of depression among the Medicaid population and the uninsured population who will come into Medicaid than the population at large. So whether this is going to work as an incentive or not, I don't know. I don't think it's a bad thing to try. I personally, just doing, as somebody interested in health policy, would have liked to have seen it on an experimental basis before it was applied in such a widespread basis, because I don't think we know what the implications are yet. But that was their theory. The theory is it would be an incentive for people to engage in healthy behaviors. I think we will also, again, the rules about what that looks like, I think they're going to be left up to the department and the health plans, and I do think for this population, we're not going to see health plans saying that they're going to charge more if your cholesterol is too high. Some employers do that. If your cholesterol is too high, they charge you more. I think we'll see them trying to just sort of focus on, well, go to a class or do something that, you try to learn more about your health. At least I think they'll start that way. So we'll see. It'll be interesting. Okay. So I'm going to switch from Medicaid into the individual mandate and into the health insurance exchange and how that works a little bit. And I want to start out with this idea of, I told you earlier that just about everybody, I think Philip's going to go through who's exempt, right, is required to have health insurance. And there is, but Ruth was with me. We were doing a session for Gretchen Driscoll because she'd been going door to door with her constituents, and they were afraid. She was asking them just generally what she could be doing in the legislature to help them out. She wasn't bringing up health care, but they were bringing up the Affordable Care Act to her, and they were saying they were afraid they were going to get thrown in jail if they didn't have health insurance and they couldn't afford it. And I think it's very important to understand nobody's going to get thrown in jail as a result of the Affordable Care Act. Actually, one of the reasons the Supreme Court upheld the law was that they viewed this penalty as a tax, not as something that really would be considered a penalty. And the tax, I told you earlier, health insurers wanted this to be much higher. Tax is actually quite low, at least in the early years. It's the higher of $95 for an adult, or $285 for a family in 2014, or 1% of income. Yes?
Are these figures annual or monthly?
Annual. Not a lot, right? It goes up over time. You can see what it goes up to. But it is not a lot of money. Of course, you don't get anything for it. I mean, you'll see, and I'll give you an example in a minute, but we think health insurance costs are going to look like on the exchange. You'll pay more somewhat, but you'll get something for it. So we're hoping, obviously the hope was that people would decide that paying this penalty wasn't worth it. And the experience in Massachusetts, this law was based upon what happened in Massachusetts. The experience was that most people, the tax there wasn't very high either, but most people still got health insurance. But that's what the penalty is. It gets applied on your income tax. And so what the law says is you have to have coverage of a certain type through the year, so in 2014, with the exemption that you can have 3 months of lapse of coverage. And if you don't have that coverage in 2014, when you file your income taxes, you're going to have to file. So there's more paperwork. Americans as much as we say we hate paperwork, every law that we have and every approach we take that is uniquely American adds more paperwork. And so, even if it's now on the web. So you will have to file some proof that you have health insurance coverage, credible coverage. And if you don't, then you'll have an additional tax put on your income tax. That is at these rates in 2015. So you won't actually see that penalty until 2015, right, when you file your income tax. So they call it the shared responsibility payment. They didn't want to call it a tax, but that's what it is. And that's what the penalty is, yes?
Is the penalty going away once you enroll in the plan, or is it like like the Part B, where if you don't enroll, then your penalty lasts forever?
Right. So it's an annual penalty. It's a one-time penalty each year, and it depends on what you did in the prior year. So if you had health insurance coverage in the prior year that met the terms, you have no penalty. If you didn't, you pay this one time. So, yeah.
So if the individual mandate starts in January, people can't get enrolled in Medicaid until
Right.
April?
Right.
There's going to be more than a 3-month lag.
Right. So people under 138% of poverty in states that are not expanding Medicaid are not subject to the penalty, and Michigan will be determined to be in that group until we expand Medicaid. When we expand Medicaid, people between 100 and 138% of poverty would become subject to the penalty if they didn't have health insurance coverage, but those below 100 are not.
How will that new tax being generated be used, you know?
Well, it is part of one of the assumptions of how they'll fund expansion of coverage. And they did assume that there were going to be people that would choose not to get coverage, and it helps fund the coverage expansion, the Medicaid expansion, and things like that. It goes for healthcare, principally. Okay. All right, so let me talk about the health insurance exchanges. We're less than 2 weeks away from when they will open. But this is the start of a long process. It's not going to be like these big gongs are going to ring, although at the health insurers, they do have countdown clocks going for the days that the health insurance exchange is going to open. It's a big thing to the health insurers, but it's going to be a longer process than I think many people might be presenting it when they talk about it. There are actually 2 health insurance exchanges included in the Affordable Care Act. But they could look like one, and the states had the option of combining even risk pools, which nobody chose. But they're technically 2. There's this Small Business Health Options Program, the SHOP Exchange, which is for businesses. It could be for businesses up to size 100. Michigan chose to make it for businesses up to size 50. It will go to businesses up to size 100 in 2016. So this SHOP Exchange, when it opens in less than 2 weeks, will be for businesses who have less than 50 employees right now. And there is what's called the American Health Benefits Exchange. You really would have thought they could come up with a catchier title for that. But it's a very bad acronym there. Can't even, ABI? I don't think so. That's why they're calling it the marketplace. These are the marketplaces. This one is for individuals who are going to buy health insurance themselves. The only way you can become eligible for a tax credit as an individual is to get your coverage on the health insurance exchange. This is different, by the way, and I can talk about it in questions if you want, from what is being announced in the press by Walgreens and other, IBM and some others, where they talk about a private exchange. Unfortunately, they're both using the same words, but that's different. They are not putting their people into these programs. They're doing something different that many private sector employers have been doing for some time. I can explain that later, but these are public exchanges that run at the public level. I told you that, we had this discussion, this very heated discussion in Michigan about Medicaid, whether to expand Medicaid or not, that got, went down to the 11th hour, finally got approved. We similarly had a very heated discussion in Michigan, a very political discussion in Michigan about whether or not to have a state-based exchange. When the Affordable Care Act was developed, I told you, it was not considered to be, they weren't looking at it as a federal takeover of healthcare. They saw it as this really, incremental law that was based upon existing structure that was going to allow the states to do most things. They saw it as a state's law within a federal framework. And so they envisioned that most states would run these exchanges, would run these marketplaces. But and I have to say, there really is no other reason to explain this, that for almost all of the states, for political reasons, they took a position that they didn't want to help with Obamacare. Now, early on, a number of states, I think, were confused about this because they thought that if they didn't run an exchange in their state, that meant there wasn't one, that they weren't implementing the Affordable Care Act. But that's not what it means. And later states, including Michigan, who made this decision, understood that. What it means is that the federal government runs the health insurance exchange, not the state. Now, Michigan started with the idea, the governor very much wanted this to be a state-based exchange. He really understood that this law was about making the market work better. In fact, he's quoted as saying, I would have done an exchange even if there was no Affordable Care Act. He said, this is something that makes the market work better, it's good for consumers. And he wanted it to be done in Michigan by Michigan people. It's an employer. We're going to have a lot of people who are going to be employed by these exchanges. B, Michigan people would understand the healthcare environment, the health plans, help people figure out what are their best choices. And running a state-based exchange gives you more flexibility to design it the way you want, and frankly, it lowers the cost. A federal exchange layers a 3.5% tax on every health plan offered on the exchange from the get-go. States that are running their own exchanges, like Illinois, are funding their exchanges with a 1.7% tax. So the federal exchanges are costing Michigan citizens more money than if we did it ourselves. He got all of that. So he went to the legislature, said, I want a state-based exchange. The Senate passed it very quickly, and then he ran into election year politics and debates about the Supreme Court and a variety of political things on the House side, and the House side didn't pass it, and they kept delaying it, saying, well, first, we'll vote after the Supreme Court ruled, and the Supreme Court ruled, and they said, well, we'll vote after the election, then the election happened, and then they said, well, we just don't want to do it. So they proposed, Michigan first wanted to do a state exchange, then the federal government gave it an option for there to be state-federal partnerships. And they said, well, we'll do that. And they couldn't get that through. And so now in Michigan, we will have an entirely federal exchange. We have returned millions of dollars to the federal government. They had given us over $30 million to help educate people on health insurance, et cetera. We've given that back to the federal government. It's gone to other states because we could not agree to do a state-based exchange. And so when people enroll in Michigan, starting in October, for health insurance, they will actually be talking to people or working with people who are in Maryland and Virginia and not in Michigan. And so here's the map of who's doing what. And as I said, I've now seen a map that combines these two, the state and the Medicaid exchanges. It's a very interesting map, and it's going to be a very interesting, for people interested in health policy, it's going to be an interesting experiment because essentially the same states that are doing the Medicaid expansion, for the most part, that are doing state-based exchanges. You see states, frankly, who want to make this law work, and then you see states who want to make this law not work. And those states, we'll have a natural experiment to see is this a good or bad law, and how does implementation actually affect it. We'll be able to see different states' experiences with that because it's going to be tremendously variable across the country. So, here is what the coverage options, I think Phil's going to, I think, go over this again too. Here's what the coverage options are. People can go on the marketplace, individuals. Anybody can buy coverage on the marketplace, but only some people are eligible for the subsidies, and I'll talk about that in a minute. I think that's an important point. So you can go to the healthcare.gov website. It's really a lovely website, very easy. You can put in all your information. It'll help calculate your subsidy eligibility. It'll show you the different health plans in your area that you could be eligible for. There are different metal levels. They don't get you frequent flyer mileage, but they are different sort of levels of coverage: bronze, silver, gold, and platinum. All they mean are essentially, it's a little more complicated than this, but basically the bronze plan is the highest level of copays and deductibles, and the platinum plan has the lowest. And not every insurer will offer every level of plan. And actually, I think there will be very few platinum plans offered on the exchange. Platinum plan is 90% actuarial value, So very low, relatively low copays and deductibles. Insurers are very worried about that platinum plan because they think it's going to attract people who are very sick and have very high use. They really want silver. They're required to offer a silver plan, but most people think people are going to enroll mostly in the silver, in the bronze or silver plans, not so much in the others. So there is also 1/5 option that's available to people who are under 30. This is the Young Invincibles plan, and it is a catastrophic plan. So again, it has a higher level of cost sharing than the bronze plan. So it's the same essential benefits, it's the same type of coverage, but at a much higher copay and deductible, and it really is intended for young. I mean, the reason they limit it to people who are under 30 is because generally, of course, those are the individuals that don't use a lot of health coverage. Yes?
So folks who are receiving health care through their employers don't have to worry about the marketplace at all, but subsequently won't receive any of the tax benefits.
Right. So I'm going to tell you about how the tax credit works in a minute, because that's really important. As I say, anybody can buy coverage on the marketplace if they want, but only some people will be eligible for subsidies to help them purchase that coverage. So, and you don't have to purchase your coverage if you have affordable, if you have employer-offered coverage that meets certain provisions, which most people do. It's going to be hard to envision too many people that, if you have employer-offered coverage, that doesn't meet the requirements of the law. So you don't have to get it. Okay. So here's the, so there's 2 levels of assistance for people who get coverage on the marketplace. One is to help them pay for the premiums. That's a tax credit for the premiums. And the other, for certain low-income people who are between 100 and 250% of federal poverty. In our state, it will most likely be people between 139 and 250% of poverty, because people below 139 will get Medicaid, right? But there are some cost-sharing subsidies that bring, so somebody could be in a bronze plan or silver plan with very low income, and their copays and deductibles could be almost nothing. So if they're very poor, right? So there is support to bring down that cost-sharing limit. So the tax credit is provided to individuals who do not have credible coverage elsewhere, which is generally employer-offered coverage that meets certain minimum requirements, and that's affordable for the employee, basically, or government coverage. So people with VA coverage, whatever that counts as having coverage. Medicare counts, Medicaid counts, et cetera, as having coverage. And it's a little bit complicated, but the tax credit basically varies depending upon the income, and it varies. The basic affordability provision in the Affordable Care Act is to say that nobody should pay more than 9.5% of their income. To administer that, they had to actually make it up their wages on the employer side, but of their income for health insurance. And this is what this is sort of, there's sort of defined affordability as nobody should pay more than 9.5% of their income for health care. Okay, and that's what affordable employer coverage looks like. The tax credit can be paid in advance. So back on your question, if somebody is going to get coverage on the health insurance exchange and they're eligible for a tax credit, they can get it up front. They can get it paid, and it goes to not to them, but to the insurer when they pick a health plan. The risk in doing that is if your income goes up during the year, then they have to pay the government back some money, right? So we think most of the navigators and people who are helping with enrollment are going to suggest to people that they not take 100%, it can be partially, not take 100% of the tax credit in advance, just in case their income goes up, so they don't have to pay it back. And, sorry?
In terms of purchasing healthcare on the exchange, many employers exclude spousal coverage.
Mm-hmm.
So as we talk about the calculation of income, is that household income, individual income?
Yeah. So that was a problem, because the law describes it as household income. But all the employers said, we don't know what household income is. All we know is what the wages are. So they actually define it on a single individual, but if the family doesn't have affordable coverage based upon the spouse's affordability, so if they're not offered coverage at all, they can get the tax credits the family can get the tax credits on the exchange. Okay, so if you don't provide dependent coverage, dependents can get the coverage on the exchange. Okay.
Based upon
But-
their individual.
Well, yes, generally. It is based upon their individual. But how they implement that is open, is confidential. But the healthcare.gov website will calculate it for them, so they'll be able to see it. But yeah, it is basically based on household income, sort of. Yep. All right. So I just want to give you an example because we've seen, Michigan's rates. We have 13 health plans that are offering coverage on the health insurance exchange in Michigan. We had one that dropped out day before yesterday. We had 14. And probably there'll be over 100 plans that are offered. Just to be clear, it's going to be very complicated. In Illinois, we've seen their plans. There are 144 plans being offered in Illinois by a set of insurers. I know, for example, and since we're 2 weeks away, I don't think I'm giving away too much confidence, Blue Cross is going to have 12 different plans on the health exchange, with the different metal levels, et cetera. So, we're going to be a lot of plans. But we don't know, we're not going to know what the Michigan plans are until October 1st. We're not going to know their pricing until October 1st. But we've seen some other states, and we know what some of the pricing is in other states. And so this just sort of gives you an example, and I'm not going to, in the interest of time, I'm not going to go through it because you have it, but I just to explain it. You can see here how the tax credits potentially work for single adults with different income levels at different ages, because it's a somewhat variable based upon income, based upon age, et cetera. And this individual also gets a reduction in the cost sharing limit. So you can just sort of see how much for this individual, look at how much that tax credit brings down the cost of health care. It brings it down from $1,000 per month to $150 per month. And that is we're hearing that rate is pretty stable across the country. So the question that I get asked all the time, are rates going to go up or down? And the answer is, it depends. If you are older, if you're 55 to 65, probably going to come down some. If you're younger, probably going to go up some, because there's compression. Remember this whole idea of having limits on how the rates look. There's compression of the rates. But then if you get a tax credit, the rates to you might look like, even if the absolute rate goes up, the rate to you might actually go down. So you're going to have to do that calculation. Yeah.
You said that anybody could apply. What about people who have Medicare who have the supplements?
Yeah, so the supplement is not offered through the exchanges. That's a whole separate thing. Medicare doesn't change, as I said. Medicare recipients should not go on the exchange. And most people will not want to go on the exchange if they have employer-offered coverage. It will be more expensive for them because they don't get a tax credit. If they get affordable coverage by their employer, which is defined as coverage that's less than 9.5% of their income and covers at least 60% of the value of the benefits. Every employer covers at least 60%. And most will cover the 9.5. If they offer coverage at that level, they are not eligible for a tax credit. Okay? So very few people are going to go on the exchange who do that. These are the health plans that are offering. You can look at that in your list. And I just want to give you the timeline of what's coming. So exchange opens October 1st, but it's not the end. It's the beginning. The open enrollment goes October 1st through March 31st. People have time. They should not be feeling like they have to rush into things. I do want to say a word. The federal government yesterday announced their fraud hotline. There is concern that there are going to be people calling up people starting October 1st with scams and basically saying, give me your, you're going to get thrown in jail, give me your social security number, I'll enroll you in a health plan. And they should not be giving out social security numbers yet. Things like that.
Already, I've been hearing for the past couple of months, ads on the radio that say, the healthcare laws are changing, you need healthcare insurance. And so if these plans that are advertising before the marketplace becomes available, if you select one of those and it's not a qualified health plan, but you thought it was, you could get a penalty.
Well, you can't go on the exchange till October 1st. So people can't select yet. I mean, if they call Blue Cross, for example, who's doing a lot of advertising, and Blue Cross will say to them, the exchange will be coming October 1st. Here's how you get it. We'll help you. Give us your name. We'll get back in touch with you. They won't enroll people in their.
Yeah, no, I'm not talking about the big credit companies. These are
Oh well, yes, scammy companies. there are scams. I mean, it is a concern. Lots of health plans, legitimate health plans, are advertising now to build awareness. Not everybody's paying attention to those ads, but they'll do lots of blitz advertising come October. And I mean, I am concerned about the people that could be unscrupulous and could, prey on people. Seniors are very prone to this, which is why, to send you, and if any of you work with seniors, please tell them you don't have to change anything as a result of the Affordable Care Act. It's not affecting Medicare. Now, many of them are going through open enrollment today. They're going through it for Medicare Advantage or whatever. So they're confused. You can see. I mean, how complicated is this? It's unbelievably complicated, and people are very confused. It's very difficult to explain this in a simple way, and so it does open the door for a lot of scams. I'm worried about that. Coverage on the exchange begins. Actually, it can begin in January, but will begin for most people February 1st. And then we talked about the Medicaid expansion. But then this is an annual process. Starts again October 15th of 2014, except for qualifying events. So there could be, if you lose coverage, if something changes in your life that's a qualifying event, you can enroll at other times on the exchange. All right, I just want to conclude with a picture of what we think might happen in terms of coverage, because again, I think it's really important for people to understand that for most people, and somebody said it earlier, for most people, it's what you said, if you've got employer coverage, it's not changing much. I mean, there are some changes, you got more benefits and a few other things, they may have to change a little bit. Your employer may have to do some work, but for most people, this is not going to be very visible, at least initially. We are predicting, I will tell you some of the health plans are predicting higher numbers than we are. We'll see who's right. We've been having this debate with them. But we're predicting that for the first year, about 120,000 people in Michigan are going to get their coverage on the health insurance exchange. And they will almost all be individuals, not small businesses. So 120,000, that's a pretty big group. But it is by no means, I mean, look at the percent, it's tiny. 1% of our state's population is not a huge number of people that we think are actually going to get their coverage from the exchange. A lot of people, but not a big percentage of our state population in the first year. It grows over time. People are going to wait and see. Employers are going to wait and see. There's lots of predictions out there about employers are going to drop their coverage and whatnot. We don't think that will happen early. Employers are already dropping coverage, independent of the Affordable Care Act, because the cost of health care is so high. That's what the Walgreens thing is about, et cetera. But we don't think that most employers are going to drop coverage initially. Some may, some certainly will. And over time, some will. But most employers offer health insurance coverage not for a variety of reasons. And the Affordable Care Act will make a difference. It'll raise costs to some degree to them, but for many of them, if you're a small employer, if you're under 50, you're not required, and I should have said that earlier, you're not required to offer health insurance if you're under 50. So for many employers, it makes no difference at all. In fact, the most, 96% of small employers in Michigan are under size 50. They will have no impact of the employer mandate. They have an impact of a few things, but not that. There's a lot more complexity around the employer market, but essentially we think employers mostly are going to wait and see, because they offer health insurance today to attract good employees, first and foremost. And that is still important in the future.
Excuse me. Will legal residents or non-U.S. citizens be able to participate?
Right, so I think Philip's going to talk about that, but essentially the undocumented are not covered by the law. And documented residents who are here for less than 5 years are eligible for tax credits, eligible for coverage on the exchange, but not eligible for Medicaid. So they have to be here more than 5 years to be eligible for Medicaid. And you're going to talk about some of that. The last thing I want to say on this slide is look at what happens to Medicaid in our state over time. So we are projecting almost a quarter of our state's population will end up by 2019 covered by Medicaid. It becomes a very important part of the healthcare picture in our state. And I showed you earlier, but I didn't really highlight it, that we did a survey last fall on Medicaid recipients, and they were very satisfied with their plan. They weren't having difficulty getting coverage. And here is why. When we asked physicians whether they were going to be taking new Medicaid recipients and whether they had capacity to take new people who are going to get coverage under health care reform, more than 80% of physicians in the state said they do. have capacity and are expecting, these are primary care physicians, do have capacity and expect to take more patients, and more than 90% of them said they would take Medicaid patients, primary care physicians. Medicaid recipients are the most satisfied of those with any coverage type in our state. Most satisfied, much more satisfied than those with individual coverage. Those are the least satisfied people in our state, because the individual coverage, very high copay and deductible today, very hard to get, very expensive. People hate that coverage. And that's what the Affordable Care Act is designed to fix. So that's it. We have a lot more stuff for you. Yeah.
In terms of the current COBRA mandate in the markets, are people going to be sort of go to the markets instead of current coverage?
I'm sorry, I didn't hear the last part of your sentence.
Are they going to be encouraged to go to the market as opposed
To getting their coverage?
current COBRA coverage?
Oh, COBRA. So COBRA, they will have a much better deal on the markets instead of COBRA. COBRA doesn't change. COBRA continues to be offered, whether employers are required to inform their employees about the marketplaces. Encouraged, we're sort of looking into this question for an employer who asks, can I give my employees dollars to go incentivize them to get on the exchange? I don't know whether they'll do that, whether the employers will do that, or whether that would be permitted. But certainly they should be informed about the exchange, because we think that coverage will be cheaper on the exchange than for most COBRA benefit plans. But COBRA continues unchanged. The requirements continue unchanged. But we think people will be eligible to go on the exchange to get coverage if they're COBRA eligible. Yeah.
What happens, federal exchange for a place in Michigan? Can that be changed over to a state program?
Yes, it can. The legislature has to have the will to change it over to, and there's still a lot of people. I have a very good friend in the Snyder administration who worked really hard to get a state-based exchange, and he really is hoping that the legislature will switch it over. Certainly not going to happen, I don't think, for 2015, but it could happen at any time. But the federal government very much wants the states to run the program, very much. So.